Part A. In this part of the test, you'll hear 2 different extracts. In each extract, a health professional is talking to a patient. For questions 1 to 24, complete the notes with information you hear. Now look at the notes for extract 1.
Hello, Rebecca. How are you today?
Dr. Miller, I'm still having problems holding my urine until I get to the bathroom. I'm leaking before I can make it to the toilet, so I've been wearing these bulky pads. I have to wear them. My desk is at the other end of the office, far from the bathroom.
I see. Well, the last visit you said that you are not leaking urine when you cough, sneeze, exercise, or lift something. Has that changed?
No, I don't leak at those times. I'm just feeling this urgency to go and rushing off to the bathroom 10 or 12 times a day. It's a nuisance because I'm so busy at work these days.
Well, we've ruled out bladder infection and other bladder problems. It seems that you have a type of urinary incontinence called urge incontinence. It affects women across all age groups. Likely the muscles that you use to hold your urine are weak. Well, the good news is that there are treatments that work to help you to become continent.
Continent?
Continent, being able to hold your urine until you go to the bathroom. And even if you aren't continent 100% of the time, treatment can mean fewer times when you leak urine by accident.
That would be nice. How is this treated?
Well, there are quite a few non-surgical treatments for urge incontinence. Some lifestyle or non-drug treatments include bladder training or a medical device called percutaneous tibial nerve stimulation. Then there are medications.
There are a lot of choices. Could you go over the options?
Sure. With the bladder training, you hold your urine for longer and longer amounts of time.
I see.
With nerve stimulation, a thin needle is inserted near your ankle. Pulses of electricity stimulate the nerves in your leg that connect to the nerves that control your bladder muscles. And prescription medications can reduce your incontinence or eradicate it completely.
It's a lot of choices. I'm just not sure. What do you think I should do, doctor?
Rebecca, people with urge incontinence get results from all the treatments I just mentioned. But since you're busy at work and the bathroom is so far from your desk, for now, I'm going to prescribe a medication to help you with this problem.
A prescription? Well, I guess I could give that a try.
Now, I want to see you back here in about a month. Call me sooner if you're experiencing side effects from the medicines or finding that you want to do something else. I think we can get this thing worked out for you.
A doctor talking to Mr. Roy Daphnis about his planned hospital admission. For questions 1 to 12, complete the notes with a word or short phrase. You now have 30 seconds to look at the notes.
So, Mr. Daphnis, this appointment is a chance for us to talk a little about your upcoming surgery and for you to ask me any questions you might have.
Okay, yes. Well, I don't really have any questions about the surgery itself. I feel I understand the procedure quite well from all of my reading, but I do have a concern. I'm actually quite worried about how I'll go with my eczema when I come into hospital. It's important for me to follow my usual routine, you see, or it will flare up again.
What is it specifically that you're worried about?
Well, I've had eczema for years now, since I was a kid. It's chronic, I guess you could say, and there are all sorts of things that make it worse. Like getting too hot, you know? Like I'm in a room and the sun is shining in through the window and it starts getting very stuffy or something.
Okay, we can make sure that you have a bed well away from any windows if that'll help.
Yes, that would be good. Thank you. As long as I'm in an air-conditioned room and it isn't too hot, that usually helps. I also notice that certain foods and drinks make it worse. I stopped drinking alcohol years ago because it always made the itching worse. But I also have a list of foods that seem to aggravate things. So I was wondering if it's possible to give that to someone, or if I can let the hospital know so that they don't include any of these foods in my meals.
If you contact the hospital directly, they'll be able to help you with that.
Great.
Tell me, Mr. Daphnis, what's your skin like at the moment?
Not very good. You can see by my face how red it is, and the itching and scratching has been much worse lately. I think because of the stress I'm feeling about the operation. It's also really bad on my back and my legs. When I lie down in bed at night sometimes I can hardly stand it.
Do you ever get any sores or weeping?
No, my skin is just dry and very itchy. But I'm most worried that because of the operation, any broken areas in the skin will mean I'm at risk of an infection. I'm doing everything I can to prepare properly though. Instead of showers, I've been taking lukewarm baths. And I never use any soap because it leaves my skin extra dry. I know using it removes the natural oil, so I use a soap substitute instead. I'm being really careful about the clothes I wear to be sure that they aren't going to exacerbate the itching. I really don't want to be scratching it at all if I can help it, and I've been using an oily moisturiser nearly every hour. I don't like to use a lot of those steroid creams and things, but I can if you think it'll help. I see a dermatologist sometimes and he said if I don't like using them, I can save them as a last resort.
Okay, it sounds like you're doing everything you can to manage the condition, but you do need to try and relax and make sure you're getting plenty of rest. I know that stress is only going to make the condition worse.
You're right. I know I'm probably getting worked up over nothing, and everything will be fine. I'm taking an antihistamine at the moment, so that's helped with the scratching and I'm sleeping a bit better as well.
That is the end of Part A. Now look at Part B. Part B. In this part of the test, you will hear 6 different extracts. In each extract, you'll hear people talking in a different healthcare environment. For questions 25 to 30, choose the answer A, B, or C, which fits best according to what you hear. You will have time to read each question before you listen to the audio. Complete the answers as you listen to the audio. Now, look at question 25. You hear a discussion between a doctor and a nurse about spastic cerebral palsy and its classifications. Hello, doctor. What is spastic cerebral palsy and how is it classified?
Well, spastic cerebral palsy is the common type of cerebral palsy that also accompanies nearly a third of other types of cerebral palsy. The damage is in the corticospinal tract or the motor cortex. This part affects the areas that receive gamma-aminobutyric acid that is an inhibitory neurotransmitter. Spastic cerebral palsy is further divided into types according to the areas of the body that it affects. In spastic diplegia, the lower limbs are affected with little to no upper body spasticity. Most people with spastic diplegia are fully ambulatory and have a scissors gait. They may also have other problems like hip problems, dislocations, crossed eyes, or strabismus. In spastic hemiplegia, one side of the body is affected, which occurs when injury occurs to muscle nerves controlled by the left side of the brain, will cause a right body deficit, and when injury occurs to muscle nerves controlled by the right side of brain, will cause a left body deficit, vice versa. In spastic tetraplegia, all four limbs affected equally. These patients are least likely to be able to walk because their muscles are too tight, and they may also develop an uncontrollable shaking that affects the limbs on one side of the body that impairs normal movement.
Question 26. You hear a discussion about different dose rates of brachytherapy.
Hello, doctor. What are different dose rates of brachytherapy?
Well, brachytherapy is a form of localized radiation therapy involving the direct placement of radioactive material close to or inside a tumor. Brachytherapy varies by dose, mode of delivery, and the location of the cancer. High-dose rate brachytherapy is given over periods of 10 to 20 minutes. The radiation dose is delivered as a short burst using a remote after loading machine. Low-dose rate brachytherapy is administered at a continuous rate in sessions that can last up to 50 hours. In the pulsed dose rate brachytherapy, the radiation is usually delivered once every hour rather than continuously. Question 27. You hear a discussion between a doctor and a nurse about bariatric surgery. Hello, doctor. What are the different types of bariatric surgery?
Well, there are 4 different types of surgeries offered to patients. The main principle of adjustable gastric banding is to decrease food intake with the use of a small bracelet-like band placed around the top of the stomach. The band restricts the size of the opening from the throat to the stomach, limiting the amount of food a patient can ingest. The size of the opening can be modified using a balloon inside the band that can be inflated or deflated with saline solution according to the needs of the patient. Biliopancreatic diversion with the duodenal switch, also known as the duodenal switch, is a 3-stage procedure that involves the removal of a large part of the stomach, which makes the patient feel full after eating only a small meal, followed by rerouting of the small intestines to prevent food absorption. The 3rd step involves changing how bile and other digestive juices affect the process of digesting and absorbing calories. Roux-en-Y gastric bypass method is also used to decrease food intake and involves creating a small pouch. The food bypasses the rest of the stomach and reaches the small intestine, where it is absorbed to a much lesser degree than if it had passed through the stomach, duodenum, and upper intestine. Vertical sleeve gastrectomy procedure involves removal of most of the stomach, which not only restricts food intake and absorption, but lowers the levels of the hormone ghrelin that is responsible for appetite.
Question 28. You hear a discussion about oral lichen planus lesions.
Hello, doctor. What are the different types of oral lichen planus lesions?
Well, oral lichen planus lesions may belong to one of the following 6 types. Reticular is the common and usually asymptomatic that presents with a fine network of white lines called Wickham's striae, which are symmetrical and found on both sides of the mouth, usually over the buccal mucous membrane. Erosive consists of irregular painful ulcers covered by a yellowish pseudomembrane of fibrin, with the white striae all around the lesions. Atrophic is usually found as an ulcer covered by fibrinous exudate on an erythematous background. Bullous is the rarest type that is characterized by small or large vesicles, or bulli, which break open, leaving a painful ulcer. Papular is an uncommon type, consisting of tiny raised white spots with the characteristic white striae at the periphery. The plaque lesions appear as smooth to slightly roughened whitish patches, rather like leukoplakia, found over the tongue and the inside of the cheeks. Question 29. You hear a lecture about the autoimmune diseases that affect the blood and blood vessels. What are the autoimmune diseases that affect the blood and blood vessels?
Well, polyarteritis nodosa is a severe autoimmune disease affecting the small and medium-sized arteries that become inflamed and damaged. Idiopathic thrombocytopenic purpura causes damage to the blood platelets that are essential to formation of blood clots. Antiphospholipid antibody syndrome leading to damage to blood vessels. Hemolytic anemia is caused when the immunological cells damage the blood cells.
Question 30. You hear a discussion about different types of biosensing elements. Hello, doctor. What are biosensing elements?
Well, an enzyme is a protein that has a high selectivity for a particular substrate, which it binds to, bringing about a catalytic change. Enzymes are commercially available in highly purified states and are therefore useful in the mass production of enzyme sensors. Enzymes can be fixed onto the surface of a transducer through absorption, covalent attachment, and entrapment in a gel or an electrochemically generated polymer. Antibodies or immunosensors are produced by B lymphocytes in response to antigenic stimuli such as foreign invaders or microbes. When used as biosensors in immunoassays, antibodies are immobilized on the surface of a transducer through covalent attachment by conjugation of amino, carboxyl, aldehyde, or sulfhydryl groups. Antibodies are sensitive to changes in potential hydrogen, ionic strength, chemical inhibitors, and temperature. Immune sensors usually employ optical, fluorescence, or acoustic transducers. Microorganisms or microbes may be used to detect the consumption of oxygen or carbon dioxide in an environment using electrochemical techniques. Microbiosensors have the advantage of being cheaper than enzymes or antibodies and are more stable. However, they may be less selective than enzymes or antibodies.
Part C. In this part of the test, you'll hear two different extracts. In each extract, you'll hear health professionals talking about aspects of their work. For questions 31 to 42, choose the answer A, B, or C, which fits best according to what you hear. Complete your answers as you listen. Now look at Extract 1. Extract 1, questions 31 to 36. You hear a presentation by a specialist cancer nurse called Sandra Morton, who's talking about her work with prostate cancer patients, including a man called Harry. You now have 90 seconds to read questions 31 to 36.
My name's Sandra Morton, and I'm a specialist cancer nurse, helping cancer patients deal with their diagnosis and treatment. I'd like to tell you about the type of work I do, and particularly about one of my patients, recently diagnosed with prostate cancer. Let's call him Harry, to illustrate the sort of things I get involved with. Now, before we get on to Harry, I'll give you a bit of background. Clearly, my job covers many aspects of patient care, but what's the priority? Firstly, prostate cancer is in fact the most common cancer in men in the UK, with over 40,000 new cases diagnosed every year. That's a staggering number. One problem is that this type of cancer actually develops very slowly, so there may be absolutely no sign that you have it for years. So, if we're going to reduce the number of cases, it's vital that people like me get the word out to as many men as possible, that we tell them how to spot the signs of prostate cancer, like an increased need to urinate or straining while urinating. Unfortunately, the cancer can be at an advanced stage by the time patients come in for tests, at which point the available treatments are far less effective. So, let me tell you a bit more about my patient Harry. Like many middle-aged men, Harry was offered a routine health check at his local doctor's surgery. As far as he was concerned, he had no particular health problems or obvious symptoms at the time, and so he almost ignored the invitation. But he'd promised his family he'd look after himself. His wife had died of ovarian cancer some years before, so he felt obliged to go. It was during his appointment that, based on a few symptoms he mentioned, Harry's doctor decided that he'd need further investigation for prostate cancer, and referred him to a specialist clinic at the hospital. Harry's trip to the clinic started with a routine blood test, which initially showed a slightly low hemoglobin level. A further test then revealed that his PSA, the prostate-specific antigen, was high at 20. He then saw a urology consultant who conducted a digital rectal examination and biopsy. A procedure that I always try to explain to patients may be uncomfortable, but is entirely necessary. In fact, though, Harry said the 3-week interval between having a biopsy taken and hearing the outcome was far more of an ordeal. Harry told me that when he went to see the consultant to get his results, he immediately sensed he was in trouble. Although the consultant was very considerate in delivering the news, unfortunately, the indications were that Harry did indeed have prostate cancer. He was assured that the cancer was low-grade and not aggressive. Harry had suspected the worst, and though he'd tried to prepare himself for it by doing some online research, finally hearing that confirmation was still a shock. In fact, the very mention of the word sent Harry into panic, which was very unlike him. So at the time I first met him, he was very vulnerable and grateful to have someone to talk to. Of course, the response to the illness amongst prostate cancer patients like Harry can vary enormously. I've dealt with some men, for example, who haven't really realised the importance of keeping up their medication because they've felt relatively well, especially if they've been experiencing unwanted side effects. Unfortunately, though, any break gives the disease the perfect opportunity to spread into the bones, making it much more difficult to treat and a successful outcome less likely. And some treatments do cause some unfortunate effects, such as erectile dysfunction, which some men really feel uncomfortable discussing, because it's a sensitive issue. Other patients have mentioned that even though they've been given a lot of help, it's still difficult to weigh up the pros and cons of the various treatment options they're offered, from ultrasound or radiotherapy right through to radical prostatectomy. So responses like these need to be taken into account by specialist nurses when talking to patients. For me, these factors really underline the importance of the community follow-up clinics we have in my area, which address many of these issues in the provision of healthcare for cancer patients. Staff at these clinics see patients during their recovery and only send them back to hospital for treatment if they develop significant new symptoms. Seeing patients in the clinics means that staff get to know each patient and build a relationship with them, which enables nurses like me to dispense advice and answer questions. And although we have no firm evidence, staff feel that's far more beneficial to patients than attending a large hospital clinic. So we're hoping more clinics like these can become available.
Now turn over and look at Extract 2. Extract 2, questions 37 to 42. You hear a presentation in which a researcher called Dr. Milan Petricevic is talking about the relationship between new technology and medicine in the future. You now have 90 seconds to read questions 37 to 42. Hi, I'm Dr. Milan Petricevic, and today I'd like to talk about the future of medicine, particularly in relation to the current technological revolution. To many of us, it seems inevitable that medical robots, automation, and artificial intelligence will replace many jobs in healthcare. Surgical robots are becoming increasingly more precise, and right now, man-sized robots can lift and move patients and transport them throughout a hospital. Silicon Valley investor Vinod Khosla once said technology would replace 80% of doctors because machines will be more accurate, objective, and cheaper than the average doctor. He added that eventually we won't need doctors at all. However, I disagree. Instead, I think technology in some specialties will finally allow doctors to focus on what makes them good physicians, treating patients and innovating, while automation does the repetitive part of the work. So let's look at some examples of how different areas of medicine will benefit from current technological advances. Take general practitioners as an example. Many doctors choose this specialty today because they have a chance to make a long-term impact on someone's life. And it's true that GPs enjoy tremendous trust from their patients. But seeing someone only when they are sick makes it hard to prevent disease and ensure someone's long-term well-being. It's even harder to do this when waiting rooms are overflowing and you only have 15 minutes to diagnose the illness, design a therapy, and offer health advice. In the future, wearable sensors and devices that stream data to a doctor's smartphone will notify them whenever vital signs are acting up and provide them with all the data they need wherever they are. These devices will also ensure doctors only treat patients who really need professional care, making it possible to offer simple treatment advice remotely. In turn, this will increase the time GPs have to treat and advise each patient, building trust and ensuring patients act on a doctor's advice. What's more, smart algorithms will allow GPs to tap expert advice on their patients' conditions and act as a gatekeeper, connecting patients to other specialties. And these are just a few examples. So what about radiology? Well, already IBM's Medical Sieve shows how artificial intelligence algorithms can scan hundreds of radiology images in seconds, doing the repetitive job of finding malignant or out-of-place phenomenon that currently radiologists have to do daily. This technology won't replace this important specialty. Instead, radiologists will have time to supervise how the algorithm is doing, or to research and innovate, making the technology behind these devices even better. Their time will be much more productive rather than spent checking hundreds of x-rays a day. Ophthalmology will bring science fiction technologies to patients in the near future. Retinal implants might give vision back to those who have lost it, or even give humans supervision, augmenting what we can already do. In sports medicine and rehabilitation, the first forms of activity records from tech like Fitbits all focused on people who exercised regularly, but only provided basic insight into how they were performing. Now, a new generation of devices tailored to professional athletes is hitting the market, with apps providing detailed insights into movement patterns and force output in any movement. Sports medicine physicians will have concrete data to measure how athletes are improving. By the time these reach the mainstream public, sophisticated algorithms will be ready to analyze data from these devices and provide personalized suggestions to improve performance and to speed up recovery. Similarly, video consoles from Xbox to Microsoft Kinect will offer a way of monitoring how a patient is doing from a distance by seeing their progress liquidly on a screen. In oncology, this specialty will pave the way for personalized medicine. Even now, oncologists customize therapies to a patient's genetic background and their tumor's molecular makeup. Cheaper genome sequencing and measuring blood biomarkers are speeding up this process, with companies like Grail working on fluid biopsies which could filter tumor cells from blood samples. Tumors could soon be diagnosed earlier and analyzed without costly surgery. What's more, artificial intelligence could soon be used to help oncologists understand and even cure cancer. Already, IBM Watson obtains all the relevant information from millions of studies about a patient's case and makes suggestions for treatment plans most likely to work. In the meantime, patients are better informed about the disease thanks to social media communities of fellow patients. These signs all point to a bright future for oncology in partnership with new tech innovations. So what does this all point to? Well, my conclusion would be that, all in all, many jobs will be taken over by robots and automation in the coming years, but at the same time, amazing opportunities will also emerge, especially in medicine. These will require physicians to acquire new skills and improve their existing ones. In my opinion, the majority of specialties will have more time for patients and better insight into disease.